ACE inhibitors, mechanisms, clinical applications, and therapeutic benefits. ACE inhibitors represent a cornerstone class of antihypertensive medications that work by modulating the renin-angiotensin system. These agents effectively reduce blood pressure and improve cardiac function through vasodilation and volume reduction mechanisms. Understanding ACE inhibitors and their mechanism of action. Angiotensin-converting enzyme inhibitors comprise a significant pharmacological class that has transformed the management of cardiovascular diseases over the past several decades. These medications function by interfering with a critical enzyme in the renin-angiotensin-aldosterone system, a complex physiological pathway that regulates blood pressure and fluid balance throughout the body. By blocking the conversion of angiotensin I to angiotensin II, ACE inhibitors prevent the formation of one of the most potent vasoconstrictors known in human physiology. This interruption of the pathway leads to a cascade of beneficial effects that extend beyond simple blood pressure reduction, making these drugs invaluable in contemporary cardiovascular therapy. The renin-angiotensin-aldosterone system, a brief overview. To comprehend how ACE inhibitors function therapeutically, one must first understand the physiological system they target. The renin-angiotensin-aldosterone system operates as a tightly regulated cascade that responds to changes in blood pressure, sodium balance, and renal perfusion. When blood pressure drops or sodium levels decrease, the kidneys release renin, an enzyme that acts upon angiotensinogen to produce angiotensin I. Angiotensin I itself has minimal biological activity but serves as a substrate for angiotensin-converting enzyme, which is primarily located on the endothelial surface of lung tissue. This enzymatic conversion produces angiotensin II, a potent molecule that acts on multiple tissue receptors to increase blood pressure through vasoconstriction and promote sodium and water retention through aldosterone secretion. ACE inhibitors interrupt this pathway at the crucial final step, preventing angiotensin II formation and thereby modulating the entire system's function. Vascular effects and blood pressure reduction. The primary therapeutic benefit of ACE inhibitors manifests through their ability to relax blood vessels throughout the body, a process known as vasodilation. Angiotensin II normally constricts vascular smooth muscle cells, increasing peripheral resistance and elevating blood pressure. By preventing angiotensin II formation, ACE inhibitors remove this vasoconstrictor stimulus, allowing blood vessels to assume a more relaxed state. This vasodilation reduces peripheral vascular resistance, requiring the heart to work less forcefully to pump blood throughout the systemic circulation. Simultaneously, ACE inhibitors promote sodium and water excretion by the kidneys, leading to a reduction in circulating blood volume. The combination of decreased peripheral resistance and reduced intravascular volume produces a substantial antihypertensive effect that can be measured within hours of administration, though maximal blood pressure reduction typically develops over several weeks of continued therapy. Cardiac benefits beyond blood pressure control. While blood pressure reduction represents the most obvious benefit of ACE inhibitor therapy, these medications provide significant protection to cardiac tissue through multiple mechanisms. By decreasing the workload imposed on the heart, ACE inhibitors reduce myocardial oxygen demand, protecting the organ from ischemic injury and improving functional capacity in patients with compromised cardiac function. Additionally, angiotensin II exerts direct effects on cardiac tissue, promoting fibroblast proliferation and collagen deposition that leads to ventricular hypertrophy and the development of cardiac fibrosis. ACE inhibitors prevent these deleterious structural changes by limiting angiotensin II's ability to stimulate these cellular processes. This cardioprotective effect proves particularly valuable in patients with heart failure, where reduced angiotensin II signaling helps preserve ventricular contractility and prevent the progressive chamber remodeling that characterizes disease progression. Furthermore, ACE inhibitors enhance the bioavailability of bradykinin, a vasodilator substance that accumulates when ACE activity is blocked, contributing additional vasodilatory and cardioprotective effects through alternative signaling pathways. Clinical applications in hypertension management. Key points: first-line therapy for patients with mild to moderate essential hypertension, demonstrating sustained blood pressure reduction over long-term treatment. Particularly beneficial for hypertensive patients with concurrent diabetes, as these agents provide renal protective effects beyond blood pressure lowering. Effective agents for managing hypertension in patients with atherosclerotic cardiovascular disease or significant cardiovascular risk factors. Useful for treating resistant hypertension when combined with other antihypertensive agents from different pharmacological classes. Role in heart failure management. ACE inhibitors occupy a fundamental position in contemporary heart failure therapy, serving as cornerstone medications that improve survival and quality of life across multiple heart failure phenotypes. In patients with reduced ejection fraction, these agents decrease the hemodynamic stress on the failing heart and prevent the progressive ventricular dilatation that perpetuates functional decline. Clinical trials spanning multiple decades have consistently demonstrated that ACE inhibitor therapy reduces mortality rates, decreases hospitalizations for worsening heart failure, and improves exercise tolerance in affected patients. The mechanisms underlying these benefits include the reduction of cardiac afterload through peripheral vasodilation, decrease in pulmonary and systemic venous congestion through diuretic-like effects, and prevention of pathological cardiac remodeling through suppression of fibrotic signaling. For patients with heart failure and preserved ejection fraction, ACE inhibitors may also provide symptomatic relief and improve diastolic function, though the evidence remains less robust than in the reduced ejection fraction population. The class represents one of the most evidence-supported interventions in heart failure medicine, with guidelines recommending ACE inhibitor therapy as a fundamental component of optimal medical management. Renoprotective effects and kidney disease. Beyond their hemodynamic effects, ACE inhibitors provide targeted protection to renal tissue, making them particularly valuable for patients with chronic kidney disease or those at risk for progressive renal deterioration. The glomerular filtration barrier within the kidney depends on a delicate balance between vascular pressures and the filtration coefficient of the glomerular capillary wall. Angiotensin II preferentially constricts the efferent arterioles of the glomerulus, maintaining elevated intraglomerular pressure that sustains filtration but can cause progressive glomerular injury when chronically elevated. ACE inhibitors preferentially dilate these efferent arterioles, reducing glomerular pressure while maintaining overall renal perfusion. This hemodynamic effect protects kidney tissue from the cumulative damage caused by sustained hyperfiltration, slowing the progression of proteinuria and delaying the need for dialysis or transplantation. This renoprotective benefit proves particularly important in diabetic patients, where ACE inhibitors have become standard therapy for managing diabetic nephropathy and preventing end-stage renal disease development. Adverse effects and clinical considerations. While generally well tolerated, ACE inhibitors do produce adverse effects that require clinical awareness and appropriate management. A persistent dry cough develops in approximately 10 to 20% of patients due to accumulation of bradykinin in the airways, and this effect, while bothersome, does not indicate medication toxicity. Hyperkalemia can occur in susceptible populations, particularly in elderly patients, those with renal insufficiency, or patients taking concurrent potassium-sparing diuretics or nonsteroidal anti-inflammatory drugs. Angioedema represents a rare but serious adverse effect that manifests as swelling of the face, lips, tongue, or throat. This condition necessitates immediate medication discontinuation and requires careful evaluation to distinguish from other causes of airway swelling. Symptomatic hypotension may occur, especially when initiating therapy or when adding other vasodilatory medications, requiring dose adjustment and careful monitoring in vulnerable populations. A reversible elevation in serum creatinine often occurs early in therapy due to the hemodynamic changes described above, and small increases in baseline creatinine should not automatically trigger discontinuation if the patient tolerates the medication well. Common ACE inhibitor medications. Key points: lisinopril, long-acting agent with once-daily dosing that does not undergo hepatic metabolism. Enalapril requires hepatic conversion to its active metabolite enalaprilat, suitable for patients with liver function adequate for prodrug activation. Ramipril, long-acting medication providing sustained blood pressure control with convenient once-daily dosing. Perindopril, effective agent with favorable hemodynamic profile and cardiovascular outcome benefits in multiple clinical trials. Drug interactions and contraindications. Clinicians must remain vigilant regarding potential drug interactions when prescribing ACE inhibitors, as several important interactions can substantially alter drug effects or safety profiles. Concurrent use of potassium-sparing diuretics, potassium supplements, or nonsteroidal anti-inflammatory drugs increases the risk of dangerous hyperkalemia and requires careful monitoring of serum potassium levels. Loop diuretics or thiazide diuretics can potentiate hypotensive effects, necessitating dose adjustment if hypotension develops. Lithium clearance decreases when ACE inhibitors are added, potentially leading to lithium toxicity. This combination requires careful monitoring of lithium levels and possibly reduced lithium dosing. Absolute contraindications to ACE inhibitor therapy include pregnancy, particularly during the second and third trimesters when these medications increase risks of congenital malformations and renal dysfunction in the developing fetus. A history of angioedema related to previous ACE inhibitor use represents another absolute contraindication, as recurrence risk remains substantial with rechallenge. Severe bilateral renal artery stenosis constitutes a relative contraindication, as ACE inhibition can precipitate acute renal failure in this anatomical setting. Monitoring and patient management. Optimal ACE inhibitor therapy requires systematic monitoring to assess efficacy and detect potential adverse effects. Blood pressure measurements should occur regularly to evaluate the adequacy of blood pressure reduction and guide dose adjustments toward target goals. Renal function assessment through serum creatinine and estimated glomerular filtration rate helps detect acute declines that might warrant intervention, with small increases from baseline often representing expected hemodynamic effects that typically stabilize. Serum potassium should be measured at baseline, shortly after initiation, and periodically during ongoing therapy, particularly in patients with renal impairment or those taking concurrent medications that affect potassium handling. Patients should receive education regarding medication adherence, the expected timeline for therapeutic effects, and symptoms warranting medical attention such as persistent cough, facial swelling, dizziness, or signs of infection. Gradual dose escalation over several weeks often improves tolerability and may minimize symptomatic hypotension, particularly in elderly patients or those with volume depletion. Regular follow-up appointments allow clinicians to assess symptom response, reinforce lifestyle modifications including dietary sodium restriction and weight management, and make therapy adjustments to achieve blood pressure and clinical targets. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.